ladies and gentlemen. Thank you for inviting me. Some slides of my topic will overlap that of Thomas that we heard before. My disclosure. Okay. You have heard of borderline resectable lesion before, and the locally advanced cancer is more evolved locally, but the difference between a borderline lesion and a true locally advanced is sometimes or often very difficult, as you know. While you can imagine resection after neoadjuvant treatment in borderline lesion, it's less often the possibility in locally advanced cancer. But first, before speaking of treatment, I think it's important to correctly evaluate your patient with locally advanced cancer. For example, many patients are addressed to a consultation with old CT scan, and when you have a CT scan exceeding 3 weeks, you have the possibility of development of metastasis in the lung, in the liver, and so you may treat metastatic cancer and not a true locally advanced. Otherwise, as said Thomas before, a lot of locally advanced cancer are in fact metastatic. For example, in the LAP07 study, we have performed an ancillary study showing that circulating tumor cells were present in about 10% of patient high diagnosis, and the patient who had CTC had a worse prognosis compared to those who did not. Otherwise, it's, as you know, very difficult by imaging to exactly estimate the invasion of LAPC. And in some cases, inflammatory, peri-vascular, due to acute pancreatitis that may reveal a cancer, or intraductal papillomucinous neoplasm may mimic tumor extension. However, that should not always contraindicate surgery. 2 examples here, both tumors on the right have been resected and were LVO. And a study by William and colleagues have shown that when you think that IPMN is unresectable, in fact, you can miss possibility of surgery in up to 20% of cases because the aspect of invasion, in fact, is inflammatory or mucus fluid around the vessel. So probably you should overestimate the extension of IPMN, malignant IPMN. Otherwise, patients with locally advanced cancer do not represent a homogeneous group. In the LAP07 trial, a post-analysis was performed by David Verneret and Frank Bonnetin, our statistician, and they show that four values were differentiating patient: age, tumor size, albumin, and pain. And taking into account the 4 values, 3 groups were built, and as you see on that slide, red curves, patients with good favorable factor with age, low tumor size, good albumin level, and no pain, had a much higher overall survival probability than those who did not. And Demi Verneret and Frank Bonnetin have built a nice nomogram for LAP07 that you will have soon on your smartphone, would be available. And you can see that a patient at low risk, young age, not too big tumor, and good albumin, no pain, has overall survival probability of more than 2 years, in contrast to patient Z with large tumor, lower albumin and pain, who has a probability of survival of 8 months. I think it's very important in the next studies to separate or to take into account this heterogeneity. What are the therapeutic objectives in LAPC patients? First, of course, to increase survival, but also to try to control symptoms and pain particularly. Of course, you should do this treatment with the aim of maintaining the quality of life. And sometimes it allows secondary resectability, and you should discuss this possibility whenever possible with the multidisciplinary group and particularly the surgeons. A big question over the past decade is, what about upfront radiotherapy? The data that we had with prospective study by Schoeffer or Laurer were contradictory. Schoeffer showing that chemoradiotherapy frontline was worse than chemotherapy, while Laurer and colleagues showed that chemoradiotherapy was probably better than chemotherapy alone, but you notice that they are pretty small series. So there were no answer to this question, and the reason why probably frontline radiation therapy is not suitable has been shown before by Thomas as well. At the time of diagnosis, the condition for the patient is not optimal to receive radiation. They come with pain, jaundice, denutrition, and anxiety. It's probably not a good condition to perform a heavy treatment with chemoradiotherapy. And of course, tumor aggressivity and presence of micrometastasis at the diagnostic, you don't know. So two retrospective studies have shown that possibly induction chemotherapy before local treatment like radiotherapy should be better in patients. Uge and Krishnan have demonstrated that. And there's the reason why the LAP07 study was built with induction chemotherapy with gemcitabine or gemcitabine plus erlotinib, as you know. And the first message of that study is we have excluded 39% of patients after the 4 months period of chemotherapy. That was exactly the same in the phase 2 SCALOP by Somnath Murji and colleagues, with a smaller effective, but exactly the same conclusion about exclusion of patients. 1/3 of patients were excluded before second randomization due mainly, like in LAP07, due mainly to disease progression, metastatic or locally. So this induction chemotherapy may allow to identify patients that are not candidates for local treatment, local radiotherapy or other, we will see, or even surgery, of course. Do we prefer chemoradiotherapy or chemotherapy alone? This question was addressed by a LAP07 study, and as you know, there was no significant difference in overall survival between the two arms. So there was no superiority of chemoradiation therapy versus continuing chemotherapy in that trial. But the conclusion is that chemoradiation is not the standard of this treatment, but it remains 2 options, chemoradiotherapy or chemotherapy alone. In that trial, chemotherapy was well tolerated, showing that quality control is very important when performing radiation therapy. And we found encouraging results concerning about survival with 15.2 and 16.3 months in patients who achieved the second randomization, and these results are similar to the phase 2 SCALOP study. And there is a need now to identify those patients who could benefit the most of chemoradiation therapy. In LAP07, of course, there were deviations of the plan, but they did not overall influence the survival. But major deviation were seen in up to 18 patients, and in this patient, we have seen more grade 3/4 toxicity, and the survival was not significantly, but a trend to decrease survival. There is a need for improvement on radiation therapy and quality real-time assessment. Our colleague in the US propose a new study with locally advanced by first stratification with MAT-CAT status, and then starting with gem-nab-paclitaxel for 3 months, and after that they are randomized for different time of radiation therapy with optimized radiation, for example IMRT, versus continuing chemotherapy. And Christopher Crane from MD Anderson is the PI of this study. And if you decide to perform chemoradiation, what type of drug, what type of chemotherapy you use to sensitize the radiation? The SCALOP study has answered this question and confirmed what a lot of people have done before. Capecitabine is probably at this time the best agent to be used with radiation therapy compared with gemcitabine, as shown is in this nice paper published in the Lancet Oncology 2 years ago. Now there are new treatment options in locally advanced cancer, and first, increase in efficacy, potential efficacy of chemotherapy. We have patients with locally advanced cancer. Many investigators has used this type of chemotherapy, Thierry Conroy, of course, the first 10 years ago, and they found interesting response rates with the limits that response rate is very difficult to assess in locally advanced cancer, of course, but there was some patients who underwent resection after that, and the median overall survival was interesting in some study. After that, new study were provided, and more and more investigators proposed to perform chemoradiation after Folfirinox, Folfirinox being the induction chemotherapy. And in this study, you had pretty higher rates of secondary surgery with interesting R0 rate of resection. I just have to say that we have to be careful with embarking a Folfirinox in a patient who is not in so good condition. On the left column, you have in this retrospective study by Medgest and collaborator in the western France, the group 1 of patient is retrospective. This patient had the Thierry Conroy criteria, and they had exactly the same survival as published in the New England Journal of Medicine, around 11 months in median. The group 2 were patients who did not fulfill the criteria of Conroy. They were older, had not so good general condition, and even a little cholestasis. And as you see, the overall survival dropped a lot because it was only 7 months. And for today, it's local advanced cancer our subject of interest. And as you see here, the results of survival are not so good in that study. But of course, this is not a randomized one. And it's true life. And in true life, locally advanced cancer survival was only 11 months. Many prospective studies are running for pancreatic cancer, and I select 2 studies now running in Europe. The study of Michel Ducreux, Néopon, accord 12, gemcitabine versus Folfirinox, which is a French logical strategy. The hypothesis is to increase progression-free survival of 3 months with Folfirinox compared to gemcitabine. And the second study proposed by Celgen and with Philippe as main investigator is a phase 2 with open study with 6 months of chemotherapy using gemabraxane, with here time to progression as primary objective, time to failure. Many other therapeutic options are emerging in local advanced cancer. You have heard probably of radiofrequency, percutaneous electroporation, high-intensity focus ultrasound, photothermic dynamiode, 125, stereotaxic radiation therapy, and even gene therapy with TERGAP, the study of Louis Busquet and colleagues. Of course, it's difficult to propose some conclusion on this technique that are at time in evaluation. Just a short word of stereotaxic radiation therapy, locally advanced cancers, 16 study, near 400 patients, and the rate of secondary resection is only available in 2 studies, and it was low. It was safe, no mortality, median overall survival difficult to conclude. What is probably interesting is the result of pain in 5 of 6 studies. It was a positive one. And same for a 3 study about quality of life. Final question is it possible to reconsider surgery after an induction therapy in locally advanced cancer? I have, like many of you, the problem of a surgeon who see a young patient and say, oh, this is a locally advanced cancer, not metastatic, it's good news, finally. But go to see Dr. Hamel, he performs some chemotherapy, and I see you after I go to operate you. It's probably the case in 10 to 15% of patients until we had Folfirinox. So I'm very cautious with that, and I say to my surgeon, please don't say you will, to the patient, you will be surely operated after neoadjuvant treatment for locally advanced cancer. And this meta-analysis already shown by Thomas before me, the GLN, very known one, is pretty optimistic. As you can see in the red section, the resection was proposed in a third of patients in that meta-analysis. As you know, a meta-analysis mixed a lot of study. Many of them were small, of course, non-randomized with various treatments. So please don't take into account the figure of 33% of resection in locally advanced cancer, true locally advanced cancer after neoadjuvant treatment or induction treatment. This study were the first one showing the rate of resection in a true locally advanced cancer, and you can see that it was from 7 to 85% of patients, which of course raised the problem of the different type of population and the different type of surgical decision in this group. In the true life, again, LAP07 study was based on a pretty weak chemotherapy with gemcitabine alone or plus erlotinib. And when we asked to the investigator, only 18 of the 442 patients, so 4% of patients were operated on, and 6 were operated before the second randomization. Maybe this patient had more borderline than a locally advanced cancer, we don't know, or they should have a tumor response. But between 85% in a study and 4% in a prospective study, you see there is a good gap between the percentage. So we have to learn more. And something is difficult. The re-evaluation after neoadjuvant chemoradiotherapy, both of these patients with these tumors were thought to be remaining locally advanced, but finally they were operated on, and both had only fibrosis around the vessel and no tumor. So you see it's very difficult, of course. And you see that the accuracy of evaluation after vascular envelope after adjuvant treatment is very difficult, with half of patients with a wrong diagnosis. I'm a bit late, so I will finish. Decrease in tumor size and vascular contacts may indicates to you a possible chance of resection. This is the only patient for which you have to discuss the surgery after neoadjuvant treatment. And finally, with Folfirinox, you could have a nice rate of patients with YPN0 resection, and probably this is the future to test this Folfirinox schema. And of course, for the moment, only a retrospective study but in the future, of course, prospective. And the take-home message for me today is you have understand the intrinsic difficulty to evaluate locally advanced cancer before and even after neoadjuvant treatment. The systemic treatment required on first intention and no radiotherapy frontline. Of course, we have to optimize the type of chemotherapy using more aggressive chemotherapy, and of course continue parallelly to work on radiotherapy. And finally, Folfirinox is very promising but need prospective assessment in locally advanced cancer. Thank you.